Welcome to our educational video on Coolief, cooled radiofrequency neuroablation of the hip joint. The most important part of this procedure is optimization of the fluoroscopic view. Here, we're going to show you how to do this very safely and correctly. Our initial fluoroscopic view will involve a scout image of the pelvis. In this scout image, we would like to crisp off the pubic symphysis and obtain appropriate visualization of the obturator foramen. In this image, we can see that the obturator foramen are rather symmetrical. Our initial fluoroscopic image seeks to crisp off the pubic symphysis and verify that we can adequately assess the volume of the bilateral obturator foramen. Once we have this initial scout view, the idea here is to move the camera more caudad in order to open up or increase the volume of the obturator foramen. This can be accomplished by moving the fluoroscopy unit approximately 10 degrees incrementally caudad. With each increase of 10 degrees, we can see that the volume of the obturator foramen increases. You can see from this next image that we've really begun to open up these obturator foramen. In our second to last image, you can see that we've now optimized the volume of the obturator foramen. However, this is not our final image. What we would like to do is come cephalad 5 degrees. The reason will become apparent very soon. As you can see, we are a little bit less than optimal volume for the obturator foramen. Once we have this final image of the pelvis, we are now just about ready to start the procedure. The fluoroscopic unit should not have to be moved again in the majority of cases. The fluoroscopy unit is now positioned over the hip joint to be ablated. Another important part of this procedure is obtaining an appropriate prep and sterile field. This is a rather large surface area, and we need to be very aggressive with our prep. I like to make sure that I prep from the umbilicus all the way out laterally and everywhere in between. With our approach, it is very important to make sure that we triple prep here and clean the medial aspect of the thigh. This is going to be for safe passage for the obturator accessory branch. After obtaining an appropriate prep and draping, we now need to demarcate the appropriate anatomical landmarks. Of primary importance with this technique is the delineation of 3 anatomical landmarks: the anterior superior iliac spine, the pubic symphysis, and the femoral crease. The anterior superior iliac spine is easily identified via palpation, and we can make a mark right over that anatomical landmark. The pubic symphysis lies right over the pubic bone, and that can be demarcated with a dot as well. Once we have palpated and verified the position of the anterior superior iliac spine and the pubic symphysis, we can then connect our dots. By raising the thigh just an inch or two, we'll be able to visualize the femoral crease. To perform a successful hip joint radiofrequency ablation, there are 2 primary nerves that we need to assess. The first and more superior is the femoral accessory branch. The femoral accessory branch runs in a cephalocaudate trajectory at approximately the 12 o'clock position of the acetabulum. Its location can be seen here. If we were to take a direct approach towards this target, we would place the bladder and colon at risk as they will be in our pathway. Once we can see our appropriate target, we now want to anesthetize a pathway to that target. The area superior to the femoral crease is an area that we would like to stay away from if at all possible. The risk of the procedure increases as we approach the area superior to that femoral crease and inferior to the inguinal ligament. By noting our target on the fluoroscopic image, we take our introducer and we begin to move at a perpendicular approach to that target, as can be seen in this fluoroscopic image. We can then anesthetize a tract from this perpendicular approach to our target. Of major concern during this procedure is not to violate the integrity of the hip joint capsule. Avoiding an intra-articular pathway to this target is of paramount importance during this technique. Once I have identified the target lesion site, I will retract the introducer until it lays at the edge of the femoral crease along that trajectory. That is where I will anesthetize and then enter the skin. I am now going to manipulate the introducer towards the target lesioning site. It is very important during needle introduction that we stay away from touching the labrum. We do not want to inflict damage to the labrum while performing this technique. This approach should keep us well away from the labrum. As you can see from this approach, we are maintaining a superomedial trajectory at all times. This will keep our lesioning well away from the joint. With this introducer position, if I merely start to pick up the introducer, I can feel, via tactile feedback, the periosteum just under my needle tip. Once I have the introducer in the appropriate position, we will begin our motor stimulation. We will place the probe through the introducer and secure it with the Luer lock. Once the probe is secured to the introducer via the Luer lock, the radio-opaque band is easily visualized. You can see here that the radio-opaque band is at the 12 o'clock position in reference to the acetabulum. At this point, we will move forward with motor testing. 2 Hz to 2 volts is a standard, and we will look for any type of twitch response. Any type of twitch response would necessitate replacement of the introducer. Once we have verified that there is no motor twitch, we can gently instill local anesthetic through the side port prior to radiofrequency lesioning at 60 degrees centigrade for 2 minutes and 30 seconds. Always remember that adjacent tissue temperatures are 80 to 90 degrees centigrade. At the conclusion of lesioning, the probe can be unlocked from the Luer lock and more local anesthetic can be injected, or the apparatus can be removed all at one time. At the conclusion of the lesion, a second lesion can be made. That lesion should be made slightly more cephalad than the initial lesion. This image shows safe placement for a second lesion, slightly superior or cephalad to the initial. The obturator accessory branch lies at the midpoint between the inferior aspect of the incisura and the medialmost aspect of the femoral head. If we draw a horizontal line using one of our introducers, Our target would be the halfway point between them. At the intersection of the two introducers will be our lesioning site. To maintain comfort for the patient at all times, it is important to anesthetize a pathway towards that lesion site. By placing our local needle over that lesion site and then retracting it down below the femoral crease, we can find an appropriate insertion site for the initial injection of local anesthetic. Many questions have been asked about this approach and how it's related to the neurovascular bundle. As we will see as we demonstrate this technique, the neurovascular bundle lies well medial to this approach. Simple palpation of the femoral artery and the neurovascular contents can be done with the hand. However, the use of ultrasound is also appropriate here if felt by the practitioner. Identification of the neurovascular contents in femoral artery can be noted with the marking pen. Once the practitioner feels that they have adequately assessed the neurovascular bundle, we can move forward with assessing our target lesioning site. This safe approach is ensured by maintaining needle over bone at all times. By simply placing the introducer over the target lesion site and retracting along the ischium, we can then anesthetize a pathway towards that lesioning site. Once appropriate local anesthesia has been obtained, the introducer can then be manipulated into optimal position. Optimal position would be at the halfway point between the inferior-most aspect of the incisura with the medial-most aspect of the femoral head. You can see here that the introducer is now in the appropriate lesioning position, and when I overlie the horizontal, you can see the appropriate intersection of the two introducers. Gentle traction over the introducer will allow tactile feedback, noting that the introducer tip is over periosteum and optimized in position. Once the needle is in position, we can now unscrew the stylet from the introducer and secure the probe via the Luer lock. Once the probe is secured via the Luer lock, we can see that the radio-opaque band is in optimal lesioning position. Here, we will perform motor stimulation at 2 Hz to 2 volts and verify no twitch response. Once we have verified no twitch response, we can then gently instill local anesthetic via the side port prior to radiofrequency lesioning at 60 degrees centigrade for 2 minutes and 30 seconds, remembering that adjacent tissue temperatures will be at 80 to 90 degrees centigrade. Optimal second lesion position will be slightly inferior to the initial lesioning site. By simply withdrawing the introducer, allowing the needle tip to now lie where the radio-opaque band was, we can now perform a second lesion safely. Once appropriate introducer positioning is verified, motor stimulation can be carried out at 2 Hz to 2 volts. If a second lesion is desired, motor stimulation should also be carried out at that second lesioning site. The typical site for a second lesion is when the needle tip lies at the same point as the radio-opaque marker for the first lesion. Motor testing for a possible second lesion should occur at the point where the needle tip lies where the radio-opaque band was for the initial lesion. Once final needle tip position has been verified and motor stimulation has been found to be negative, then we can begin with the radiofrequency lesioning process at 60 degrees centigrade for 2 minutes and 30 seconds. At the conclusion of that lesion, the second lesion can be placed slightly inferior along the same trajectory. This second lesion site should have the introducer tip lie at the previous location where we saw the radio-opaque band. As we can see from this image, the needle insertion site will be over the ischium. As you can see, by manipulating the introducer very slowly, several millimeters at a time, we will approach the target very safely with minimal discomfort to the patient. At this point, we are needle over bone, right over our lesioning site. As you can see from this slow and deliberate approach, we are able to obtain access to that lesioning site very quickly with minimal discomfort to the patient. During placement of the introducer, it is interesting to note hand position. The more we advance, the more the trajectory becomes cephalad and superior. This is because of the orientation of the ischium. You can clearly see that due to the increased angulation of the ischium, a more superior cephalad approach is needed in order to maintain contact with the ischium and for proper placement. Once the introducer is placed through anesthetized skin, we can quickly manipulate the introducer towards the target lesioning site by increasing our angle of approach until touchdown on the periosteum at our lesion site. Note that during our approach, the distance between the neurovascular bundle and the introducer. Thanks for watching our educational video on Coolief cooled radiofrequency neuroablation. As you can see, this is a very simple technique that can be done safely with minimal discomfort to the patient.